talked about last week? Y'all remember? Yeah, that's right, because you have to decide. And PPM falls under what? And that applies to everybody in here once you graduate school, right? Okay, so PPM, a subcategory of moderate, and point of care is minimal, all right? So the three things that the point of care test must have, just read the highlighted stuff. It's what? It has to be for home use, right? It's got to be simple and accurate, and it has to pose no or to minimal risk of harm to the patient. All right, so what are these representations of? Include cells are indicative of what? BV. And how would you collect these? On a wet mount, essentially. Fern testing. Fern testing tests for what? Amniotic fluid. It can only be found on what type of women? Pregnant women. All right. Postcoital.
Timing's everything.
Timing's everything. Okay. All right. And must be collected within 2 hours after. And urine sediment examination. Remember, what was my favorite cast that I talked about? Lactic cast. And where are those found in? What disease states? Kidney disease. Very good, y'all. Very, very good. Remember, I just said memorize this. I really, I don't have nothing. Sorry. All right. And then I will not give you a picture of this, but if I say that you receive a report and there's greater than 3 eosinophils per high power field, that is indicative of. All right, so let's get into our lecture for today, if I can figure this out. Show up. So what do we know about hematology? Because I know y'all got some pathology stuff. What y'all know about it? What you think we're talking about? Blood, right?
Blood cells.
Red blood cells. And what are some of the formed elements of blood? You remember?
Red blood cells. Hemoglobin, plasma.
Plasma is the liquid portion. Yeah. Serum's the liquid portion. Your formed elements are your red blood cells, your white blood cells, your platelets. Okay? All right. All right, let's get to this. Let me see. All right, TLOs, y'all can read TLOs. ELOs, y'all can read that as well. We're going to talk about those blood and blood functions, the formation of red blood cells, white blood cells, and thrombocytes, which are platelets. We're going to talk a little bit about morphology and their significant clinical significance, and some implications of white blood cell variations. This is your lovely, lovely reference. This comes from chapters 32 through 34. So here's a clinical introduction scenario. A 34-year-old male presents to the Troop Medical Clinic with worsening fatigue, pallor, and shortness of breath on exertion. Vitals are stable, but conjunctival pallor is noted on exam. There is a stat complete blood count that reveals a hemoglobin of 6.4 grams per deciliter, an MCV of 72, and markedly increased RDW. Review of the peripheral smell shows microcytic hypochromic RBCs with anticytosis and poikilocytosis. Based on these findings, the provider initiates a workup from iron deficiency anemia and evaluates for chronic blood loss. So that's just a bunch of stuff we don't know about. But at the end of this lecture, you all will know what that means. This is the agenda. That's on the ELO and TLOs. All right. So characteristics of blood. Remember, we got our liquid. It's liquid connective tissues all over. We have about 5 liters that we carry around with us every single day. Our three most important functions of blood is transportation, regulation, and protection. Please highlight transportation because I will ask you about transportation, all right? So it moves oxygen, nutrients, hormones, and waste products. It regulates your body temperature, your pH balance, and fluid balance, and it protects you from infection, immune response when those white blood cells come out and attack whatever's attacking you and your body. Okay, remember I talked about formed elements versus our liquid? So we got it now. Serum and plasma is the liquid portion. Our formed elements are those RBCs, white blood cells, platelets. Okay, also known as erythrocytes, RBCs, leukocytes, WBCs, and thrombocytes, platelets. Okay. All right, so this is just a visual representation of what I just talked about. So if you did not understand it and you read better this way, this is just a breakdown of those components of blood. Okay. All right, so these are our formed elements. Now, I will not test you all on any differentials or smears. You will not be looking at this stuff as pHs. But you just need to be familiar about what is being tested and what we're looking at for you all for your patients. So if you look at letter A, those red blood cells are almost like little circles in there that are kind of like pale pink, those are red blood cells. Your reactive lymphocytes, which is letter B, you'll see an increase when you have infections in your patients. We'll see a lot of those. Neutrophils is letter C. Eosinophils. I talked a little bit about eosinophils last week. Do you remember what I said? If you see greater than 3 eosinophils in a high power field, what is that indicative of? Remember? Good, infections and rhinitis. Good. Neutrophils, or PMMs, we also call them polymorphonuclear leukocytes. We have monocytes. I don't think I talked about it, but monocytes can also be, monocytes and basophils can also be a part of infections as well, but I will not test you on that. Platelets are those little small discs, little fragments in there. You have lymphocytes. If you see an increased amount of lymphocytes on your reports, just know that's probably some type of viral infection. And then bands, which is considered a shift to the left. Those are a lot of immature white blood cells in the blood. Okay? So hematopoiesis overview. Hematopoiesis is just saying that this is the process in which all blood cells are produced, developed, and matured in the body. All right, we have two locations, medullary and extramedullary, and the series of steps includes proliferation, differentiation, and maturation. Okay, so hematopoiesis is what? All blood cells, the process, right? So if I said erythropoiesis is what? There you go, you got that. All right, so medullary is the primary site, and extramedullary are other organs. Okay, you have your 3 stages: proliferation, differentiation, and maturation. And then how the blood cells are produced, they all start as stem cells. They'll break up into either a myeloid or lymphoid, and then they mature from there. We'll go into that later on. So even though this note is really, really tiny here on the bottom, it's very important for you all, okay? A normal myeloid to erythroid, it may show up on your test as ME ratio. So if you see an ME ratio of 1.2 to 1 to 5 to 1, that's normal. But anything that is greater than 6 to 1, that can indicate an infection. It can indicate chronic myeloid leukemia or erythroid hypoplasia. And you'll see this note again in these slides, okay? So make sure you have that now. All right, so EPO, these are just some regulatory factors in hematopoiesis. EPO is produced in the kidneys. It stimulates that RBC production in response to those low oxygen levels. And you may see that increased production in high altitudes or in anemia. So we are gonna, there's so many anemia slides, so just know anemia. Just know anemia is not necessarily a diagnosis. Anemia means there's probably something else going on with your patients, and they may have to require further testing. okay? All right, so we have thrombopoietin TDO. This regulates production and maturation of platelets. Cytokines, signaling molecules, and this is found in various blood cells. You have interleukins, which is a subset of cytokines, and this is signals in the bone marrow to increase white blood cell production. And then lastly, colony stimulating factors, proteins that stimulate growth and differentiation. Just know the EPO, okay? All right, so here is a visual representation. Anybody that's ever went to lab school, we've all seen this, okay, when you go through hematology. This is just showing where once those cells come out of that bone marrow, they start off as stem cells. And once they get split up into either a myeloid stem cell or a lymphoid stem cell. So for this lecture, we're only going to focus on the myeloid portion, okay? The myeloid portion will break off into either red blood cells, platelets, or granular leukocytes. Your lymphoid stem cells will break off or mature into your agranular leukocytes. And you see that little note again? You see how that keeps popping up? This is important. Okay. All right, so production of red blood cells, erythropoiesis, all right? So these are concave, anucleated cells. They live about 120 days in your body before being recycled again. All right, so like I said, my predecessor loves to put these little dollar signs on there. Now, I will not post this picture on your test, but just be able to, I want you to be able to look at this and understand it, okay? So if you look at number 1, those are the red blood cells. These are old red blood cells that are in the body, and it's encompassed in a macrophage. And y'all know what macrophages do? They eat, right? Phagocytosis. So as they're dying, those macrophages will go ahead and engulf those red blood cells, and then they'll start distributing the parts, right? So it'll break up the globulin, the heme, right? The globulin, once it's out of that macrokaryocyte, it becomes an amino acid, and that is used for protein synthesis. The heme will then attach to a transferrin, and so it's just floating on that transferrin, and it'll go into be absorbed by that liver where it becomes ferritin. Then once it becomes ferritin in the liver, it gets on that transferrin again, goes back into the bone marrow. So then that iron, globulin, vitamin B12 will then all be processed together to start all over to become a new red blood cell, circulate in the body for 120 days, and the process starts all over again. Okay? So you produce about 200 billion red blood cells a day, which is pretty amazing. I think the body's pretty remarkable, actually. You have erythropoiesis regulation, responses to hypoxia, and the function of the EPO is signals the bone marrow to increase RBC production, including those reticulocytes. So if we look at this illustration on the bottom, it's kind of the same. We're just breaking off that big illustration that we had, and we're just showing the myeloid process there of how a stem cell becomes a red blood cell. So it's just showing it as a stem cell or a blast. It becomes a erythroblast, then a normal blast, and once it ejects this nucleus, which is that reticulocyte, the reticulocyte will float in the body for a little bit and then get recycled back, and then that erythrocyte will stay in the body for 120 days. Okay? So anytime there's an increase of immature cells, like blasts, there's an increase of reticulocytes in the body, just know that there's something going on with your patients. Something negative going on. Yep, I sure do. Okay, so reticulocytes are seen in anemias. Anytime you see an increased amount of reticulocytes, think anemia, okay? For just generic anemia, an increase in reticks, a decrease in hemoglobin. For hemolytic anemia, think increased reticks, decrease in hemoglobin, but also an increase in bilirubin. And then for sickle cell disease, you'll see an increase in reticks, decrease in hemoglobin, but you'll always also see that hemoglobin as So I'm not gonna go too much into spleen. Y'all had AMP, y'all have pathology. Y'all have any questions on spleen? Because I'm not gonna test you on spleen. But we're gonna talk about it because I have to. So, reduced immune functions. All right, so some common labs that you'll see would be normal CDC values. They may persist, but this is just saying that it's less effective at fighting and retaining or fighting certain infections. Thrombocytosis is increased platelets, so you see an increased platelet count on your labs. Hollow jolly bodies are nuclear remnants of red blood cells, and that's usually seen when there is no spleen in the body. And then lastly, you have your overwhelming post-splenectomy infection. You may see normal CDC values, and these people tend to have increased amount of bacterial infections as well. All right, white blood cells or leukocytes, they all have a nucleus, but they do not contain hemoglobin. Hemoglobin is only found in which cell? Red blood cells, yes. All right, so they're far less, more numerous than RBCs, and they live about a couple hours or a couple days. Now, lymphocytes live a little longer. They can live and move to the tissues and stay for months. Do you know why that's the case? You know what travels on the lymphocytes? Those immunoglobulins, right? So anytime you get a vaccine, right, and those antibodies are on those lymphocytes, sometimes that can stay in the body for that immunity, okay? All right, so here are these are types of white blood cells. Again, I will not present any cells to you, but just know the names. And I'm gonna keep saying it. What is eosinophils associated with? Infection, allergies, yes, okay? Basophils have, they're large and dark, they have very deep cytoplasmic granules. Neutrophils are multi-lobed, that's that third one here. Neutrophil, okay? Lymphocytes are a little smaller. They're very round, they have a very central and minimal nucleus. And then you have reactive lymphocytes. If it's reactive, then it's being engaged and it's going after something, it's attacking something. And then lastly, you have those monocytes, which is that cell on the bottom, and they have that kidney-shaped nucleus with an abundant cytoplasm. Okay, money slide. Money slides are very important. Okay. Neutrophils are essential for eating bacteria and fungus. Okay? Eosinophils, we already said that too many times already, right? Basophils, you have hypersensitivity reactions and are also seeing allergies as well. Monocytes, they also they do phagocytosis and have antigen presenting to the T cells. You have your B lymphocyte and T lymphocyte. We are not going to go into that today, later on. And then you have NK, which are those natural killer cells, and those are for innate immunity. Okay? What was the cell that I said that dealt with, what are the abundant amount of cells you'll see in viral infections? What? Lymphocytes. All right. Plasma cells, and immunoglobulins. All right, I'm gonna go through this really quickly, all right, because you will not see this video. So, plasma cells, this is when the body enters an infection, those B cells are activated, they will differentiate, and however they differentiate will determine how they will invade those pathogens. All right, so here are all the different Igs, M's, G's, A's, E's, and D's. I think you all go over this in pathology, so I will not double test y'all. So IgM is that first type of antibody that's produced. It neutralizes viruses and bacteria. You have IgGs, those are the most abundant in the body, and it does provide that long-term protection against infections, and it does cross over the placenta when the mama is having, offers that immunity to newborns for those first couple days that they're on Earth. You have IgAs that are found in all your mucosal linings, so respiratory, GI tract, and genital urinary tract. IgGs are involved in allergic responses, in defense against parasites, and then IgGs are just found in low concentrations in the bloodstream. So platelets or thrombocytes, okay? They're developed on the myelostem into megakaryocytes, okay? And so the megakaryocytes are these big cells that are in there, and then once they mature, they split up to 1,000 fragments, and they're enclosed in that plasma membrane, okay? They are disc-shaped, they have no nucleus, and they are big in platelet plugs and ADP polyphosphates. We'll talk about that in another lecture, not today. But they are found in the body they stay in the body for about 10 days. Another money slide. That's the previous guy's money slide, not my money slide. I'm not going to touch on this because even in lab school, we go into this and we don't even go this deep. But I'll talk about it because it's in here. So thrombocytopenia. All right, it's dealt with bone marrow failure. In these patients, they have thrombocytopenia, they easily bruise, they got a lot of mucosal bleeding, and very fatigue, very tired. Right? So you'll see like I said, in anemias, you'll see an increase of what? Reticulocytes, and a decrease of hemoglobin. Good. So as long as y'all have that, that's what I really want y'all to get. And then we'll go on a little bit more into the specific types of anemias, but that's really what I want y'all to get. So this is a very, they don't look like this anymore, this is really old, but just so you have an example of what a complete blood count will look like when you pull it up on your computer. And so this has, the white blood cell count is on the top, and then underneath it has the breakdown of each of those cells. And as you can see, the EO percentage is higher. And so the suspected or definitive is eosinophilic anemia. That's just all that's saying. Now you all will take, because this is just a portion of what's going on with the patient, but you all will take that, you will match that up with your clinical, whatever you see clinically, if you run other tests, things like that, just use this as a puzzle piece to diagnose your patient. So a CBC, or a complete blood count, is all the cellular components, all right? Lucky for you, y'all will not run these tests. You will collect them in that purple top tube, and then you will give it to us, okay? And no, we do not hemolyze samples. Who said that? Who was that came up to me? You hiding? We don't hemolyze your samples, okay? Give it to us. We will run those tests for you and get them out. This is one of the most common lab tests, and it gives you that comprehensive insight into your patient's overall health status. So these are the components that are analyzed in a complete blood count. You do need to know these because you'll see them. Now, like I stated before, when I put it on the test, I will give you the test that's run, and I will give you the normal values. So please do not memorize reference values. We don't even memorize reference values because, like I said, it's slightly different from each lab based off your local population, okay? All right, so we have our white blood cells that we talked about a little bit. We talked about red blood cells that carry oxygen throughout the body. Then we have hemoglobin. Hemoglobin is the measurement of the amount of hemoglobin. This is the protein in RBCs that carries the oxygen. Then we have hematocrit, which is the percentage of the blood volume occupied by the red blood cells. Then you have MCV, which is mean corpuscular volume. This is the actual volume of RBCs, okay? Then we have MCH, mean corpuscular hemoglobin. This is the average amount of hemoglobin per red blood cell. Then we have MCHC, which is mean corpuscular hemoglobin concentration. That's the concentration of hemoglobin within the red blood cells. Then we have red cell distribution, RDW, and that is the different sizes, variation of sizes. And then lastly, we have our platelets that are crucial for blood clotting and preventing of excessive bleeding. Yes, sir, your question?
How are we seeing this?
How is what?
How is the
Okay, so the question was, how is the mean corpuscular hemoglobin and the mean corpuscular hemoglobin concentration different? I'm going to explain that in the next couple slides, okay? All right, but I'll tell you. Let me not. You know what I'm saying? That was kind of rude, right? Okay, so mean corpuscular hemoglobin is deficiency anemia, know that one. That is the most classic type of anemia, all right? And you will see the landmarks or laboratory landmarks of iron deficiency anemia is that low MCV, that low volume, that low hemoglobin, that low hematocrit, which is the percentage, and low ferritin, low iron, microcytosis. And microcytosis just means that the red blood cells are really, really small, okay? All right, so here's a white blood cell. As you can see, they've got the normal reference range there. You see how it's there? That's how I'm gonna get it to you, okay? 4,000 to 11,000 cells per microliter. Critical values, anything that's less than 2,000 or greater than 30,000, you will be getting a phone call from us. That is part of our protocol. So any type of critical values, we have to get on the phone with you all to let you know what we found, okay? That's all you need to go with that slide. All right, so the rule of three, this is important. This actually should have the $sign. You will not be doing any math, but because y'all are smart, I don't think you really need a calculator for this. But you do have to know the rule of three. And so pretty much the reason why it is, the rule of three encompasses the red blood cell count, the hemoglobin count, and the hematocrit. And the reason why that is because you all as PAs can do a hemoglobin test as a point of care test. And so if you know that if you get a hemoglobin result and it's low, and you can't get them a CBC at the time, you can kind of get a roundabout of what their red blood cell count is and what their hematocrit count is, okay, based off that hemoglobin. So the rule of three is the hemoglobin count is generally 3 times greater than the RBC, and if the RBCs are normochromic and normocytic, meaning they have a normal amount of hemoglobin in them and they are normal size, then the hemoglobin times 3 will approximate the hematocrit. Yeah? Got it? Yeah? Okay. So yes, you will get something like that saying you got a patient that came in, you can only do a hemoglobin, the hemoglobin was this amount, what is the RBC and the hematocrit count, okay? Alright. So RBC times 3 equals the hemoglobin plus or minus 0.5. The hemoglobin times 3 equals the hematocrit plus or minus 3, okay? All right, so hemoglobin is what is highlighted? Just read it, somebody.
Indicates the index of the oxygen carrying capacity of blood.
Dang, yes. All right. And just like I said, anemia, because they love to talk about anemias in the PA program, so please know this one, the finding, all right? It's located with iron deficiency anemia, blood loss. Your symptoms are fatigue, weakness, pale skin, shortness of breath, all right? And you usually treat those people with iron supplements or blood transfusions if needed, okay? And we'll go a little bit more into sickle cell disease a little later on, okay? Hematocrit is the percentage of the total blood volume. That's all you need to know for this slide. All right, money slide. Sir, this is where it gets a little bit better for the MCH and MCHC, okay? Explains it just a little bit more. So MCV is your size, so actual size of the RBCs. Your MCH is more of the weight, okay? So this provides info on your oxygen carrying capacity of your red blood cells. Then you have MCHC, which is the color, and RDW, which is the variation in size. And so when you see RDW, you're also looking for the degree of any cytosis, which is just means variation in RBC size. Okay? Is it a little clear? A little bit. So this is just that, remember I was saying about those balloons. So if you didn't like the chart and you need some colorful pictures, this is just another visual representation of what that means. Okay? So each one of these balloons, the volumes are all the same, right? So it's going to have normal MCV. But each balloon has a little bit of dye, a little bit more dye as you go along the slide, right? So the balloon on the left has a little bit of red dye, so that's low MCH, low MCHC. That may indicate hemoglobin synthesis. okay? Okay, so this is an example, this is really old, this is from like 2003, and now I'm learning, I'm the oldest one here because I was in the military in 2003, but it's all good. They don't look like this anymore. For you all, it's important, the stuff on the left, everything on the left side is important for you. As far as those histograms, it's not really applicable, it's more applicable for us in the lab. So this is just showing what a CDC plus a differential would look like, if you ordered it. Okay. Alright, so this is just another version of what we already talked about. You just need to see it look differently. We will talk a little bit more about bands, and that's a shift to the left. So anytime you see a bunch of bands on a report, just know that there's something going on with your patient. They've got some type of blood loss or some type of hemolytic anemia going on because that bone marrow is producing those immature RBCs out quickly, okay? This is just what it looks like normal. This is a normal differential. You will not see that as a PA unless you just want to come to the lab and look under the microscope. All right, so cytosis. Do you remember which test that correlated with on the CDC? It started with the R. RBW, that's correct. So increased variation in size of RBCs. Okay, yeah, that energy drink kicked in, huh? Good for you. All right, poikilocytosis. This is just a variation in any shape of RBCs. So a lot of times there will be both anticytosis and poikilocytosis in those anemias. Okay, different shape sizes. We got all kinds of stuff going on. Something's going on with that patient. We don't know what time. I'm just rambling, and I want to make sure. Okay. Abnormal RBC morphology. All right. So when sickle cell disease, a lot of the cells in there will look. It says drepanocyte, but I think they look like little crescent moons, which is where that sickle cell name comes from. Okay. You have acanthocytes, has these spiky projections coming off the red blood cells. That's usually seen in people with low cholesterol levels. They may have some issues with absorbing fat. Target cells are important, so please highlight target cells or podocyte, and it looks exactly like the target emblem, okay? And that is found in thalassemia. Schistocytes are just they look to me, when I see them under the microscope, look like the red blood cells have little bitty bites in them. They're just fragments of red blood cells. That's also found in hemolytic anemia. And then burn cells have spiky projections, but those are found with people who have high BUN or creatinine levels. So what is the other name for a target cell? And it's found in what condition? Cool. See, I told you everybody's gonna do good on my test. All right. RBC inclusions. Just know that Howell-Jolly bodies are associated with sickle cell disease. And what were the cells that were also in sickle cell disease? Remember the crescent-shaped ones? Drepanocytes. Correct. Basophilic stippling is seen in lead poisoning and thalassemia. Pappenheimer bodies are found in cytoplastic anemia and hemolytic anemias. Cavigrins are found in megaloblastic anemia, and Heinz bodies are found in G6PD deficiencies. Okay? Howell-Jolly bodies are really important, and G6PD Heinz bodies are really important. This is just a really nice picture. You will not see these. But I will talk about vitamin B12 and folate deficiencies a little later on, okay? Just kind of keep that in the back of your mind. The Puget anomaly have these neutrophils, they're bilobe nuclei. They're seen in benign disorders, usually asymptomatic. Toxic granulation can be seen with inflammation and bacterial infection that are associated with what those cells again? Sonophils, I know, y'all ready to go home? I know. All right, ESR. So remember, I had talked about ESR in that first lecture, the first time we met at 1500 on a Friday. This is that test, that non-specific marker test for inflammation. Okay. Test takes about an hour or so. You can't really make. It just kind of helps you get to your diagnosis. Let's put it that way. Okay. So the faster those formed elements of that blood fall, the more likelihood that they have something. The slower that they fall, they just may be okay. All right. So if you see down there it says anemia increases ESR due to the decreased RBC to plasma ratio. Okay. All right. There's that anemia again, and it's highlighted, so it must be important, right? So in anemias, the ESR levels are greater than 20 millimeters per hour, and your patients will present with fatigue, weakness, maybe some pallor, some pale skin, and they need them iron supplements and blood transfusions. That's all you need to know off of this slide. And this is just what an ESR looks like. You all will not be running these like our lab people does. And so based off of what I had said, which ones of these, okay, pretty much what it is the tubes on the bottom, and we stick a tube through the blood collection tubes, right? And we put it up against like a ruler, and we let it sit for an hour, okay? That's pretty much what we're doing. That's why I don't like this test. But based off of what I had already been rambling about, which ones of these are actually normal? Because remember, normal, they're gonna fall slow. If it's abnormal, the red blood cells are gonna fall faster. So which ones do you think are normal? 1, 2, 3, 7, correct. And so those abnormals, depending on the gender and the age, could be what? 4, number 5, you say that's like at 70. Number 6 is at 80. Number 8, 105. All right. So ESR will change depending on gender and age and some other factors. And you know what, y'all? I think that ELOs, look at all that stuff we discussed. Any questions? You don't take a break. I have to take the next one because that's what your class leader told me. But y'all want to take a break for a couple minutes and then we can go knock out. You say what? What is that? All right, so let's do. Come back 150. Is that okay? Okay for y'all?
None of them were anything. That poor. Yeah. Like send it off and then spin it. Yeah, well, I said.
Going to get stuff. Oh, you're good. Good.
Just heard.
Wait.
One second.
Super serious.
So I had to dig this out. I'm trying to. Here you go. Check. Barrel trunk. I'll take the area quiet. And then I'm trying to figure out little things. Like, seems like a lot of the physical in there. Just those little things. And I just wonder how it's going to be presented. It could be any diagnosis, or it could be, hey, here's the diagnosis. Right, contraindication. Try not to before I can.
Any questions on hematology 1? Hematology 2? No questions? Alright. Hematology 2. So this is like 41 slides, but you know it's really like 35 slides, so. Okay? So remember I was talking about it's gonna be very heavy on anemias, leukemias, lymphomas, and platelet disorders. Okay? TLOs, ELOs. Okay? References. Alright. Clinical introduction scenario. A 19-year-old basic trainee presents with persistent fatigue, heavy menstrual periods, and recent easy bruising. Physical exam reveals pallor and scattered petechiae. A complete blood count shows a hemoglobin of 7.2, an MCV of 68, platelets of 42,000, and a white blood cell of 1.8 with 30% blast on a peripheral smear. The provider initiates an urgent hematology referral and discusses possible anemia, thrombocytopenia, and leukemia. Alright, I don't know what else is here. I really should have fixed that out. Alright, so we know anemia, right, is that condition in which the oxygen carrying capacity of blood is reduced. And this may be caused by the destruction of red blood cells, excessive blood loss, and a decrease in production or maturation of those red blood cells. Okay, remember I said anemia, the reticulocytes are what? And hemoglobin is?
Oh.
Alright, this is just an anemia workup. And you all have been through A&P, so I will not, you can look at it, it's very nice. Alright, so this is that money slide again, right? So money is what is important, right? So cause of anemia. Remember we said decrease of RBC production? Okay, this can be with hypoproliferative anemia. Because you know, I don't know if y'all knew, but I like hypoproliferative anemias, okay? Like I really like it, alright? And it's associated with my favorite anemia, iron deficiency anemia, okay? So what's my favorite anemia?
Iron
That's what you gotta know. And the rest of these, oh yeah, I did say sickle cell. And what was that cell that you see in sickle cell anemia? Do you remember? Yeah, it looks like a sickle. It looks like a crescent moon, right? Yeah. All right. So then we have an increased red blood cell destruction that's seen in hemolytic anemias. And then we will discuss a little bit about the intracorpuscular, which is inside of the cells, and then which means that it's prematurely breaks down. And then you have extracorpuscular hemolytic anemia, which is destroyed by external factors. And then RBC loss due to bleeding, so that could be an acute blood loss or chronic blood loss, either by GI bleeding or menstrual disorders. But because we're military, right? What kind of out of the three are you going to see anemias? 5, we will put it in our reports as polychromation. So polychromation is just a visual representation of what we see, okay? So make sure you understand the difference between the two, okay? Because I may present it as reticulocyte test or I may present it as polychromation, so just know. Retic count, yeah, this is just another, if you like a panel, this is just another way to read it, okay? Hypoproliferative is very good. All right, red cell indices. Red cell indices are the quantitative measurements of the red blood cell size. Do y'all remember which test that was? Huh? Volume. MCV is volume. MCH was what? Weight. And the concentration was what? MCHC. Okay. All right, so iron deficiency anemia, that's your most common, and anytime you see most common, you know you're gonna get tested on it, so just know it. Low iron levels, your lab findings will be low hemoglobin, low MCV, low volume, low MCH, and high RDW, okay? Megaloblastic anemia, I did say we're gonna talk about it a little bit. That's caused by that vitamin B12 or folate deficiency. In megaloblastic anemia, you'll have findings of a high MCV, so very large and very immature red blood cells. And then lastly, hemolytic anemia, that's that destruction of red blood cells, and that can have a variable retic count. But I told you, high retic count, low hemoglobin. That's what y'all need to know, okay? All right, money again. All right, volume is size, MCV is size, MCH is weight, MCHC is color. And RDW is associated with what is this word with the A? Gangliocytosis, okay? So make sure you're linking those two. So if you're seeing a report and I'm like, ooh, I see a bunch of gangliocytosis everywhere, then you know that it's associated with what? What's my favorite one? Iron deficiency. And you see how iron deficiency is associated with all these indices? You see that? That means it's very important. All right, iron metabolism and regulation. All right, so this is just saying that retics indicates your bone marrow activity. Red cells indices classifies the different anemias based on size, weight, and content, hemoglobin content. And you know, we produce about 200 billion red blood cells a day. Pretty remarkable. And we require about 20-25 milligrams of iron per day. So this is just a nice slide. It just talks about iron metabolism regulation, right? So you absorb, how iron is absorbed in the duodenum. Regulates from the liver, it's transported. Iron binds to transferrin, right? When it comes out of when it is production, it rides that transferrin, goes into the liver, it comes back out as iron, it gets recycled back, right? By macrophages. But this is important though. Ferritin is a key lab marker of iron stores, so that is actually important. So transferrin transports what? Iron. And ferritin is what?
Lab marker.
Alright. Okay. Iron panel profile tests. Okay? So these are the tests that will be found in your iron profile panels. Serum iron, ferritin, TIBC, which is total iron binding capacity, and transferrin saturation. Oh, see? Ferritin showing up again. So look, what does that mean, right? Okay. And are we doing this off of? No, I'm not asking. Y'all got it. Serum ferritin, just no serum ferritin, okay? TIBC is the transference capacity to bind to iron. It is binding iron's transportability. And then your TC sat. This indicates indicates percentage of transferrin that is saturated with iron. And just know that, of course, like I said, I'm gonna provide you with those reference ranges, but just know that the ferritin levels are slightly lower in women, or no, sorry, ferritin, these are normal, but sometimes they are a little bit lower in women. So yeah, this is just a little bit more if you want to read. Look at that. There's already, that looks so similar to what y'all gonna see again. My gosh. Iron deficiency anemia, okay? And that's all I'm gonna say on that slide. All right, so we have microcytic hypochromic anemia. So that just pretty much means the red blood cells in there are really tiny, and that means that they're very pale. That's what that means there. And there we go again, IDA, okay? IDA is associated with microcytic hypochromic, right? So all of your RBC indices are low, with the exception of RDW, and RDW tests what?
Variation in size.
Yes, variation of sizes. So you're gonna have low everything, but you're gonna have different types of red blood cells in there. They're all gonna look different shapes and sizes going on, okay? With this, your patients will present with fatigue, weakness, pale skin, shortness of breath, and you wanna provide them with some type of iron supplementation. All right, normocytic normochromic. That just means that the cells look normal. They're normal sizes, they got normal amount of hemoglobin in it. But with these type of anemias, the red blood cells might be normal, but the hemoglobin and hematocrit are low. And then your MCV, MCH, and MCHC are normal. I know it has a dollar sign on there, but I think I chose not to. I didn't mean to do that. I mean, I know I'm ready to go, but I didn't mean to do that. No. Okay? That was truly accident. Hold on. Woo, hold on. Okay. Yeah, we're just gonna go. It's not today. What did I do? I was at normal. Okay, we were here. Okay, and I said the word well. Okay, now macrocytic megaloblastic. So that just means that these cells are large and they're blasted, means anytime you think of a blast, think of immature cells. And then when there's a whole bunch of immature cells in the system, then your body's trying to either try to fight something off, or it means something else, okay? Usually, remember I said vitamin B12. So if you see macrocytic megaloblastic, think of vitamin B12 deficiency, okay? And it's a hallmark finding specific to pernicious anemia. Okay, macrocytic normal, non-megaloblastic. This is related to the most common conditions for alcohol-related anemia. You might have that issue in the military. I don't know. Maybe. You'll have a slightly higher MCV. The MCH will be normal. Alright, so one of these algorithms is important, and this is the most important algorithm, okay? So, microcytic anemia algorithm. The MCV, if it's less than 80, then for you, as the physician, will say, oh, okay, I get this CBC back, MCV is low, I need to do some follow-on testing. Some follow-on testing that you need to go ahead and run would be an iron, a ferritin, and a TIBC, all right? And if all of that is low, what's that daggone anemia again? I know, they're getting on my nerves with this, but hey, they want y'all to know it. All right, macrocytic anemia, if the MCV is greater than 100, you want to go ahead and run a B12 and a folate, okay? If the B12 is low, you're looking for a pernicious anemia, maybe some type of severe malnutrition or GI problems. If the folate is low, some type of malnutrition, GI, liver disease, and if it's normal or high, myeloproliferative disease, liver disease, or CVA. anemias, yes, this is a true money slide. Okay. True money slide. Hemolytic anemia is associated with that sickle cell anemia, and you have that abnormally hemoglobin S, right, with a high MCH. And those sickle cells, those drepanocytes will be all over the slide. Okay. So a defect of red blood cell membrane is called hereditary spherocytosis. And that just means that the RBCs don't have that soft pallor in the middle. It's just like a pink circle in there. And the NCHC is high. So it has like a really high hemoglobin concentration on here. And that is kind of the same. We have the osmotic fragility test. We'll talk about that a little bit more in block 2. But you'll have these high spherocytes. And that is indicative of hereditary spherocytosis. So please highlight that. The rest of these, if you can read it, that's fine. But hereditary spherocytosis is really likely. Okay. Yeah. And what is that target cell called again? Podocytes. And then what kind of anemia is it found in? So this is just saying that thalassemias are broken down into alpha and beta hemoglobinopathies, and it's a variable degree of anemias, but y'all won't ever go that deep. If somebody has this going on, you would already refer them to like hematologist or oncologist, like they're already out of your hands. So, all right, and this is just another breakdown between alpha and beta hemolytic anemias and thalassemias. So alpha. Your symptoms, they're severe anemia in those newborns and probably are incapable of life. They're probably not going to live much, not too much longer. And then in your beta, this is associated with severe anemia, fatigue, delayed growth. Like I said, you've already referred this patient. Nice slide, but we will talk more about malaria when we get more into micro, because we have to hit micro again. I know y'all had a whole freshman semester, but I have a little block on malaria, but you will not need to know that till later on. Just know that there will be sites we'll see, okay? All right, so diseases of white blood cells, we have 2 main categories, leukemia and lymphoma. So leukemias, we're dealing with those from the blood and the marrow. Lymphomas, we're concentrating more on that lymphatic tissue. Okay. And some things you will look at is that white blood cell count, differentials, and symptoms. Leukemia, when leukemias, you're going to see a lot of those blasts, a lot of those immature cells with genetic mutations. And some tests that you'll see with leukemias will be the complete blood counts with differentials, your blood smears. There may even be some bone marrow aspirates or biopsies, flow cytometry, and cytogenetics. Lymphomas, since we're looking at the lymphatic tissue, there will be biopsies, some immuno flow cytometry, and do y'all remember what complexity that is? What kind of complexity is that? Y'all remember? High complexity, which means what? Y'all not running that, right? So don't worry about it. But I just thought I'd throw that out there. And then leukopenia, which is a complete blood count with differential, retic count, and bone marrow biopsies. Okay, shift to the left. Remember I had said this earlier about bands. If you get your CBCs back with differentials and we're saying we found bands everywhere, there means there's a lot of immature cells in that slide, okay? So specifically immature neutrophils are called band cells. So going from myeloblasts, band formed, segmented neutral. Blasts are the most immature, segmented neutrophils are the most mature. Okay? So shift to left or blast crisis, that's not good. Alright. So if you go into a family medicine clinic, you may deal with babies, right? And so if you have a child, right, we do a CBC, and you see that we put on your report that there's greater than 20% lymphoblasts, then you need to start thinking of acute lymphocytic leukemia, or ALL, okay? For older adults, and there's greater than 20% myeloblast, think acute myeloid leukemia, AML, alright? Then in young adults, teenagers, people under 35, and those that are greater than 55, they're showing clinical symptoms of fevers, night sweats, and unexplained weight loss, you do a CBC, we run that differential, right? And you see on that report that we saw a bunch of Reed-Sternberg cells, know that is hallmarked for Hodgkin lymphoma, okay? Okay, so for the kids, what is greater than 20% lymphoblast is what? For the adults, greater than 20% myeloblast. And then those Reed-Sternberg cells, Hodgkin's lymphoma. That's all you have to know off this slide. Myeloproliferative neoplasms, PB, this occurs in the bone marrow, and a lab hallmark are high red blood cell count, high hemoglobin, high hematocrit levels. So this slide, like if we saw this slide, we could tell automatically that this person is producing a lot of blood, right? And this could lead to blood clotting problems and maybe an increased stroke or heart attack. And these are slightly more common in males than females. Then we have essential thrombocythemia, high platelet count, usually in excess of 1 million. These symptoms, they tend to have a lot of blood clots, bruising, and bleeding. And if it's untreated, thrombocythemia can increase the risk of blood clots, something like that. And a PMF is just abnormal bone marrow causing that fibrosis or that scar tissue. And you see a low mature blood count in presence of fibrosis in the bone marrow. And then myelodysplastic syndrome, resembles primary myelofibrosis. You'll just see a bunch of blasts in bone marrow, a bunch of anucleated bone marrow cells. And then we're almost at the end, because when I see platelets, I know that I'm almost done. All right, so platelets, you see those little purple pieces there, those are platelets in there, and that's pretty much normal. But if they look like this, and they're like similar to the size of a red blood cell, there's probably some stuff going on. And usually the giant platelet syndromes, usually if you see giant platelets, we associate that with Bernard-Solier syndrome. We're going to talk more about that in lecture 5. So just put that in the back of your head. All right, and some examples of inherited platelet disorders. So it looks like this is just kind of like a preview of what's coming next, but we will talk about on Friday, we'll talk about a little bit more about the von Willebrand disease, Bernard-Solier, and the Glanzmann, okay? So you can just read over that if you want, but we'll go a little bit more into it on Friday. DLOs. Boom, 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 boom. Questions, comments, concerns, complaints? Nobody here.